Hi, and welcome to my channel. Today we will be talking about acute rheumatic fever. Acute rheumatic fever is an autoimmune non-infectious complication of group A beta hemolytic strep infection. It's called beta hemolytic because it completely lyses the red cells. Now, acute rheumatic fever can occur after a pharyngeal infection, that's a throat infection, or in some cases a skin infection. It's more common in developing countries, and most cases typically occur among school-aged children. In some cases, there is a family history of rheumatic fever. Acute rheumatic fever occurs as a result of molecular mimicry in susceptible individuals. So let's take a look at this. During the initial strep infection, the host's inflammatory cells respond by producing inflammatory molecules as well as antibodies. In susceptible individuals, however, the antibodies that are produced are unable to distinguish between the M protein on the invading strep, which is seen as these fine hairs, and antigens on host tissues. These antigens are seen on the brain, the heart, the joint, and skin. The timeline of acute rheumatic fever begins with an acute strep infection. After this, there's a latent period of 2 to 3 weeks before the classical features of acute rheumatic fever develop. These classical features are carditis, arthritis, subcutaneous nodules, erythema marginatum, and chorea. To make a diagnosis of acute rheumatic fever, there is no singular test that is done. However, the Jones criteria is used. It is divided into major and minor criteria. It also requires evidence of a preceding strep infection. Evidence of a preceding strep infection could be a rise in anti-streptolysin O titer, a positive throat culture, or an elevated anti-DNase B. There are 5 items under the major criteria. First is carditis, and this could be clinical, meaning the patient presents with a new murmur or pericarditis or signs of heart failure, or it could be silent, meaning there is valve involvement that is seen only on echo, and the valves that are usually involved are the mitral and aortic valves. Next is arthritis, and the arthritis seen in acute rheumatic fever is migratory polyarthritis. Next, subcutaneous nodules. The nodules are firm and painless and usually occur over the knees, elbows, wrists, or spine. Next, erythema marginatum, and this describes a pink rash with a pale center and rounded margins. The rash usually occurs on the trunk and limbs, but rarely on the face. Last is Sydenham's chorea, and chorea simply describes purposeless, involuntary, non-stereotypical movements. There are 4 items under the minor criteria. They are arthralgia, fever, elevated acute phase reactants, that is, elevated ESR or CRP, and a prolonged PR interval. Definitive diagnosis requires evidence of a preceding strep infection, as well as 2 major criteria, or evidence of a preceding strep infection, as well as 1 major and 2 minor criteria. Investigations done in a patient with acute rheumatic fever include anti-streptolysin O titer, throat culture, anti-DNase B, all done to establish evidence of a preceding strep infection. Investigations also include an ECG, an echo, ESR, and CRP. Treatment of acute rheumatic fever begins with treatment of the initial strep infection, and this is done using penicillin. In some cases, it also involves treatment of the symptoms. Patients who present with arthritis are given NSAIDs, and these include aspirin and ibuprofen. In patients who present with symptoms of heart failure medications such as diuretics, ACE inhibitors, or ARBs can be given. Most cases of chorea do not require treatment. However, in severe cases, chorea can be treated with anticonvulsants such as sodium valproate. Prevention of acute rheumatic fever occurs across 3 levels. Primordial prevention is the first level, and this involves removal of risk factors. This is done by improving socioeconomic status and preventing overcrowding. Primary prevention involves proper treatment of the initial strep infection, and this is also done using penicillin. Secondary prevention is done to prevent subsequent attacks of acute rheumatic fever. This is done using penicillin as well, and penicillin is usually given for 5 to 10 years or till the patient is 21 or 40 years of age. In summary, acute rheumatic fever is a complication of group A beta hemolytic strep infection, and it occurs as a result of molecular mimicry in susceptible individuals. The Jones criteria is used to make a diagnosis. Treatment involves treatment of the initial strep infection as well as symptoms of acute rheumatic fever. Patients require secondary prevention with penicillin till they are 21 or 40 years of age in order to prevent subsequent attacks.